Thank you very much. First of all, I would like to thank AeHIN for providing me this opportunity to talk about OpenIMIS implementation status and how future challenges of implementation in Nepal can be supported by the university by including this concept or this type of modality in the university curriculum. So this presentation is especially divided into 3 parts. First is current status, where I will be giving some facts and figures about the outcomes of OpenIMIS implementation team of Nepal, especially Health Information Board of Nepal in collaboration with the Ministry of Health and GIZ. And in second part, I will be talking about my personal experiences about the about using this health insurance policy. And I will suggest some of my experience so that we can enhance the services in the days to come. And finally, as Ms. Tha introduced about my plan that we are developing Masters in Health Informatics courses. So, and we are trying to include OpenIMIS system in the curriculum of Masters in Health Informatics at Kathmandu University. So how could we do that? So there are some of my ideas. So how that will be presented. So as I mentioned earlier, so 3 objectives: current state of the art, patient's perspective, and academic institution, how academic institution can support the government about widespread or scalable implementation of OpenIMIS system in Nepal. So these are my presentation will be concentrated in these 3 areas. So first of all, I will be talking about current state of the art of OpenIMIS implementation in Nepal. And here you can see the feature of health insurance in Nepal. First, we can see the contributory family-based feature, and purchaser and split provider feature, IT-based insurance management information system, subsidized, cashless policy, and then public and private providers. So basically, in this insurance policy, one member of the family can get enrollment in this policy by paying about $30 per year, and this cost will cover 5 members of his family. So it means that for any additional member, the extra about $6 should be added for every 20,000, or in terms of dollar, about $160 to $70 per person in increment. So with that $30, about $30 insurance payment by a family, government will provide about $850 of treatment. So I'm not talking about much about this matter. So because there are different options and different packages, like for diseases like TB, HIV, and other kidney diseases, government will provide additional $850 of insurance. So it is for people of up to 70 years of the age limitation. So purchaser and provide special. Purchaser is the especially Health Insurance Board of Nepal in collaboration with the Ministry of the Health, and they will purchase service from the different primary health centers and hospitals of Nepal, including some medical colleges which are providing health services to the citizen of the Nepal. And another component IT base, as I have mentioned a talk because earlier, because this OpenIMIS is itself a software. So if we implementing this software for the automation of insurance policy, it is IT based. Subsidized to poor, more poor or vulnerable people are have special provision for their treatment. And another feature is cashless upper cap. So cashless means if we register or enroll in the system, we can go to the hospital with the card, insurance card, and we can get treatment and even medicine with the card. So no need to carry cash and give payment during the appointment of the doctor or during the treatment time. And public and private providers, many hospitals and some are government hospitals, some are private hospitals. So these are the features I have taken from the below sources that we can find in the internet. And talking about the mechanism of our old Social Health Security Committee that is collaborating with the government of Nepal, especially with Ministry of Health. So the Ministry of Health and Health Information Board of Nepal designed like policy, and then the Ministry of Health will monitor or set the quality targets and that the hospital should provide to the patient. And then some monitoring mechanism is also there because claim from hospitals or health service providers should be monitored because there could be some fraudulent activities like a false claim should be segregated and it should be rejected. Such kind of provision is also there. And main is the family will deposit some amount of money and rest will be paid by the government. So contribution medical insurance card, with that card it is possible to go to the hospital and then we can get treatment. In this slide, I would like to talk about relation of user, provider, and facilitators. This slide can be divided into three parts, as you can see. First part is service user, who are the patients or clients, household members, and they registered to this policy through the enrollment assistant, especially from the representative from health post. So he or she can visit the residency of the family and she could register the people in this system. And next is a facilitator. Facilitator is Nepal government and Health Insurance Board, and it formulates and regulates, rules, regulations, and coordination is also done by this entity, and its main role is for pooling, like how to generate money for the treatment of patient, to cover that part, and purchasing, like finding the most appropriate health service providers, institutions like hospital, primary health care centers, and they will find the appropriate hospital based on the location of the household. service user. And finally, the service provider, its main responsibility is by meeting the standards set by the facilitators or health insurance board, they will provide treatment to the patient without taking any extra money at the hospital. So finally, they will claim their treatment cost from the government. Now, I would like to talk about some facts and figures on OpenIMIS in Nepal. By this time, except two districts of Nepal, Kathmandu and Lalitpur, because these two districts are heavy, densely populated, so the number of users could be very high. That because and also this our OpenIMIS system or health insurance policy is maturing day by day in terms of resources and in terms of service providing services. So that is why gradually this system has included 75 districts of the country. So maybe in future this system will include these two districts also. There are more than 425 PSCs or hospitals or medical colleges which are providing services to the patient of the Nepal in this system based on the rules and regulation and policies of the Health Insurance Board of Nepal. This diagram shows us national population coverage. I have listened one of the presentation of August 2020. During that time, the coverage was about 9 to 10%. So within 2 years, I feel this is very encouraging that additional 9% has been coverage has been increased. So this shows the popularity of health insurance policy of Nepal government. So it is an encouraging one. And this slide shows us a gender-wise insurance, and we can see that about 5.5 million people have been registered in this system. So among them, majority like 51%, more than 51% are female, and 48% males. So it shows that participation of gender is balanced, and it is also like favoring or it is encouraging, because as the low and middle and low income country, in comparison to main population, female population are more vulnerable for different diseases and different types of accidents due to their poor economy. They have to work very hard. So this may be the one reason. Another reason is the ratio of male and female in Nepal is the female population is higher than the male population. And this slide shows us about age range of injury, and we can see that maximum age range like 15 to 29 and as the highest injury numbers, and whereas the lowest one is the age between 0 to 14, 1 to 14, 17. Sorry, age 30 to 39, 13.7. It may be like the age range differences is here only 10, and in other part like here is 15, and age between 40 to 59 is 20. So 60 above is so because of that, this could be the reason that age of 30 to 39 ranges have low participation in this scheme. Household by category, there are different categories like FCHC, female community health volunteers, normal, non-disabled, senior, ultra poverty, and others. So in total, we can see that 1.7 million households have been involved or registered in the OpenIMIS or health insurance policy of Nepal. And the highest percentage of involvement in household category is normal one. As Nepal has been divided in 7 provinces, and based on provinces contribution, we can see that maximum contribution is from province 1, and minimum contribution is from Karnali province, and which is one of the remote provinces of Nepal. So in total, the total contribution is about 12 billion Nepalese currency. So Nepalese rupees 12 billion contribution. I think this is a very good amount of contribution by different provinces or the families. And another reason this Karnali provinces contribution, because they have like limited health facilities and might be insurance assistance, number of insurance assistants working there could be less number because of the remote area. It takes like a couple of days to travel from one place to another within that provinces. So there is no good transportation system. So that could be the one of the challenges that government should find, and how to reach the people of remote area like Karnali Pradesh. It is it is a very essential task for the government to implement health insurance policy in remote area of Nepal. So this slide has been already described, sorry. And category-wise injury, FCS reach about 18,000 in terms of percentage, just above 1%. And normal, you can see 53, over 53. Null disability 1.3. Senior citizens, significant contribution 38.4. Ultra poor 4.9, almost 5, and HIV 0.7, 0.8%. So category-wise injuries have been it is this insurance policy. From this insurance policy, different groups of people have been benefited or participated in this health insurance policy for their better health. Age-wise insurance, we can see the lowest number of ages, as I explained in earlier slide in that pie chart, 30 to 39, and maximum is in the range of 15 to 29 age range. This slide shows us contribution collected in 2022, and we can see that from January, February, March, April, and this time in April, the March is the peak time. I think we can get insurance optimally 2 times around this period, April, March, and April, March, and then after August. Because I have insurance, I have got insurance around June, July. So especially we have to wait a couple of months for getting treatment after insurance. So people who know the policy earlier could timely get insured, so that they will get health facilities within the beginning of next fiscal year of Nepal. It is around July, August is new fiscal year for Nepal. So there are altogether 18.8 million claims till date. So it is a huge number. And average claims number and claim amount is shown in this slide. Average claims is 6, whereas the average amount claim per claim is 8,051 rupees, which is equivalent to $65.2 US dollar. This slide shows us top 10 claiming health services providers. Here we can see Nobel Medical College. This is its services is like it serves people, many patients than others. And our teaching hospital, Dhulikhel Hospital, is Kathmandu University teaching hospital. It is also it has also a significant role for the treatment of Nepalese citizen in its location. Here we can see some interesting statistics, because there are most rejections. As we can see in the previous slide, in this slide, Nobel Medical College has highest claim about the services they provided to the patient. And on the other hand, Nobel Medical College's claims have been rejected mostly. So this is the very crucial data for us, because we have to think for how invalid claims can be made. We have to prevent that kind of thing. And what are the circumstances or factors that influence invalid claims or false claims, because if we make false claims, then it goes to the system, and from system, reviewer committees should access and verify that claim. So if we are putting the garbage in the system, the reviewer committee, like other members, the time and resources will be wasted. So with a limited number of human resources working at this insurance policy, and getting irrelevant data and working for that is very nonsense kind of thing. So we have to think and minimize how we can reject invalid insurance, or submission of invalid insurance should be discouraged. So we need to think in that line. Claim services are mostly almost over nearly 50% of services claims are related to outpatient department, like hospitals. In hospitals, we can see hundreds of patients are there for getting their treatment every day at Dhulikhel Hospital and different hospital in the Nepal. And another is in PSC, same outpatient department, and other creatinine, other different types of services which is related to blood and urine checking. Now I would like to move into second section of my presentation. In this section, I will be talking about patients' perceptions of using OpenIMIS in Nepal. So this is my card. This is my card, so that I can share this with my will. I do not need to take permission from anyone. That is why I share this one. And this is the this one is the insurance card provided by the government to me. So this is my insurance number. So this card is this is the card. Okay, so a paper card, and it is provided after a couple of days that I get enrolled in the system by insurance assistant. So this is I mentioned this is a paper card. Okay, so And with that card, when I go to hospital for getting treatment, and I need to give this card to the hospital, and they will verify and they generate this type of slip for me, including like community scheme, government insurance with my insurance code and hospital's number and other information. So they will give a different hospital cards like this for one type of treatment. We can see here in this slide. Okay, so this one is for ophthalmology ophthalmology department, and another one is for like this is for my osteology orthopedics department. So what I am trying to show with these slides is that for every kind of diseases, like we need separate this type of paper with carbon copy paper. So one for this one, and another for like cardiology, another one for skin, another one for eye, another one. So this kind of paper is used for doctor prescription. So this is what I feel not convenient for me to instead of having this kind of hospital card like different pages. So it will be more like protected one, because this paper, separate paper, it is not easily storable, and it is very delicate for the future storing for future references. So now, based on these insurance card and my hospital card and the experiences that I have generated during different visits, my visits to hospital, I have some concern, or like I have not exactly concerned, I have some points to be mentioned, because with this we can think how we can enhance health insurance system of Nepal. It could be like a kind of input for feedback for the system. So first one is, as I have shown in this picture, like this paper, what about like adopting online enrollment and renewal process for health insurance? Because patient or the household could have access, they access the system, and they will fill up the form, and they will submit the required document, verification process, other things can be done, which can minimize the physical work of the insurance attendant. So and this is the more convenient way of living in this technological society. And also, if we can have some online type of enrollment, and we could also be notified when is the time for my renewal for the insurance policy. In fact, otherwise I need to call to the insurance assistance for this. So better to get some email messages or phone messages in phone, so that I could timely renewal for the insurance process. That would be better, I think. Getting appointment of doctor using technology, there are many hospitals where we can get admission through online portal. So how about like incorporating such kind of facility to these dedicated hospitals which are used for the serving the insurance policy of health insurance policy. So if we can have that kind of thing, We do not need to spend 1 day or 2 days for getting treatments. As I have mentioned, hundreds of patients are in queue, and it takes a lot of time for this paper-based processing and going for the appointment. It is really very hard for patients to get treatment from the hospital. Actually, this is not the part of like weaknesses of the health insurance policy. It is the part of hospital, but we all together like makes a community. So it is a problem of community. So if we could think in that way, so that we can minimize the doctor's appointment time, it will save the times of thousands of people every day. Next one is, how could I choose the first service point, PSC or hospital, as per the requirements of the other family members? For example, in my case, I am living in the province number 3, and the nearest hospital for me is Dhulikhel Hospital. So I have to choose this Dhulikhel Hospital for all of my other 4 members of the family. And if I pay more, then other members of family, we have to choose for the Dhulikhel Hospital. But but I would, because my parents are staying in another provinces, so how can they come to get treatment from that far places to here? Because there are also hospitals where they could go in short time and get treatment quickly. If we have option for different members based on their location, we can, if we can choose the first service point for individual level, not as a family level, it could be very like encouraging for getting treatment. And next is, what is the better way of maintaining historical medical records? Because these days, like technology has enhanced in such a way that now people are researching on maintaining personal health record by themselves using smartphone or cloud-based services. So in this type of this insurance system, for every visit to the doctor, we for every department, we will receive this, we will get this type of paper, and this type of paper is like, and we especially get carbon copy of this paper, not the like originally written by the doctors. It is carbon copy. So, and as you know, carbon copy, this ink fades very fast. So we cannot preserve our records based on this type of recording system. So this is very like concern issues or challenges to get this medical records of the patient. And how is possible, how it is possible to provide documents of claim to the respective patient, because they have the original, like not carbon copy, original doctor's handwritten prescription is with them and with the hospital, and they will submit that to the client. During that time, what about like sending the medical reports to the patient through email or other way, so that patient can archive their health records easily, and for it will be easily available during future references. Then collecting this type of papers, and after 5 years, it will faded away, and we do not have our records on our hand. So this is the another concern. So another thing is replacing paper ID card with other electronic forms like Visa cards and other things, and there are barcodes in every ID card. So what about replacing this card? Because of durability, portability, easy to use. So, and also what about like we have OpenIMIS, Nepali OpenIMIS Bamini, and there is some like a digitization of our hospitals treatments and labs reports that can be included in that card like that. If we have electronic card, and then if we put their every hour records in that card to maintain archive, it will be more easier for handling the many records of a patient for years. So and if we have digitized form of our records, we can process it easily rather than collecting files with paper sheets. And could we think for storing personal medical records in the enrollment card? And how could a patient client see the remaining amount of health coverage after getting treatment? For example, I have visited 3 times to the hospital for getting treatment, and I don't know how much money is remained there. If I would have any provision to see that based on that amount, because I don't know next time when I visit the hospital how much money is needed for that treatment. I don't know, so I can just guess, and I can like plan for my treatment if I know my remaining amount over there at any point of time. Are the patient health records are protected during claiming process? Because hospitals and doctors are authorized for getting the patient's record, but while submitting the documents to the claiming during claiming process, original document of the patient will be submitted to the concerned authority. So we don't know how that our privacy of the data or our identification will be disclosed, or our identification will be like protected. We don't know. And this is just like I'm talking about like only about concern. Is it necessary for the hospital to share the document, original document of the patient for claiming, so that if the patient give permission, then okay. And to whom they are giving my personal data for claiming, there should be notified to me for my privacy of healthcare data. So this kind of things we could think and enhance in the days to come. How a patient can transfer his or remaining health insurance amount to the next year. For example, just for example, I insured this time, and my health has been very good for this year, and I have not visited the hospital. And is it possible for me to transfer the remaining amount for next year? Because I haven't utilized the that amount of money in this year, or maybe sometimes I am due to my job I have to travel some places for a month and even a year. So some people may have transfer in different countries. So at that time, they will not getting treatment from the first point service center. So in this scenario also, if we can transfer our previous remaining amount to for the next year, it will be more encouraging one to utilize the government health policy. Storing personal data, medical data in the electronic card will be the use of new technology. Next, how to claim the amount of those medicine purchased outside. I have encountered with many occasions that when I get treatment from the doctors, and doctors recommended many medicines, and most of the important medicines I could not find in the dispensary of the hospital, and I need to buy from outside medical or pharmacy. So during that time, I have to spend extra money for purchasing the medicine, and there is no privilege that I can submit that claim to the claim like the health insurance board of Nepal, because in my the facility gives me about 850 US dollars equivalent services, and my equivalent services is still there, but I have to pay extra money for the medicine that I could not find in the pharmacy. So we have to find some solution in this scenario, how to give compensation to the patient in this type of circumstances. And this is a common thing that in different, in almost all health service providers, they are lacking of most essential medicines, and many people have experienced this kind of thing. Getting sufficient medicine until next follow-up. Just for example, I have diagnosed one disease, and then my follow-up requires after 3 months, and the time I am getting treatment, that hospital dispensary will provide me medicine of only 1 month, because my follow-up time is 3 months. So then only for taking more medicine, I need to make appointment and get like a doctor's permission or prescription, and go to the pharmacy, and I can get the medicine. So although the follow-up duration is 3 months, 6 months, or maybe 1 year, it depends on the disease. This is not my domain, but in my experience, at least medicine, the quantity of medicine should be provided to the patient until the next follow-up. That kind of thing should be regularized by the health insurance authority. That will be very helpful for the people in this busy world. And all about exploring about opportunity to enhance the functionality of OpenIMIS. This is not my any grievances, and not my any negative feedback. It is like, because we have this kind of challenges, then we have to think what are the are all these challenges are relevant or not. First, we have to segregate them, and all relevant challenges we have to give solution for them one by one in the days to come. Now I come to the last part of my presentation, and which is about how to integrate OpenIMIS in an academic curriculum, because now for Nepalese people and in the health sector, OpenIMIS or health insurance have been one of the integral part of living. So that is why it means that the clients or the service seekers numbers will be very high within 5 to 10 years. So in this regard, we have this time very limited resources at the health insurance board for managing, handling, and providing services to the people or patients. So that is why, how could we, being a part of university, how could we help, or how could we collaborate with government so that we can produce more human resources, we can generate new ideas to tackle with the problem faced by not only by the patient, but also by the health service provider, and also problem of health insurance board about like detecting fraud claiming and or optimizing the work performance of the entity. So for this, bridging the gap between academia and government bodies is necessary. So university can contribute for the capacity development for different stakeholders of this domain or this health insurance policy fraternity in order to mitigate current and future challenges. Such for example, scalability, number of users will be increased day by day. Efficiency, like we have seen that due to different reasons, hospitals claims hospitals have claim amount of money they spend for the treatment of medicine of the patient, but they are getting very late. Like it has been mentioned somewhere that within 1 week the reimbursement should be done, but it is not happening. So we can work for that and optimization and developing sufficient content for academic institution. Any courses or any activities should be should be of standard. All of us know. So we can include this OpenIMIS course as a 1 credit project, as a 1 credit course, or 2 credit course, or 3 credit course. What 1 credit course is in our system is that 1 hour direct contact to students for 15 or 16 weeks. So this much content should be there for us to launch 1 credit course, and for 3 credit 45 to 48 hours contents should be there. So yesterday I completed the introduction of OpenIMIS courses from our AeHIN that was provided in e-learning courses by Swiss partner. So there we see about 2.5 hours courses, and if we go and read extra references and extra documents, it may go to 10 or 15, might be 15. If we consider some lab works and some demonstrations, some like reading articles. So we can enhance content like including acts, rules, and regulation of the health policies or of the country, and annual reports and case studies of OpenIMIS implemented in different countries. So that it will be full of content, and then we can run as a course at the university. And only the objective of including OpenIMIS at the university as a university courses is that it is just about the contributing by the university for the capacity development of the country, so that because we need a lot of human resources and technical skills to make successful operation of this health insurance policy of Nepal. That is why I think this is the way. And another thing is that if students study any courses, they always seek for their career or job opportunity. So there could be kind of like understanding so that anyone who is good in this subject could find a job in some way, somehow, and the health insurance board or Ministry of Health will provide such create such environment for such aspiring students. Next is how we can collaborate is like problem finding. It is not about problem, but it is opportunities finding within the current OpenIMIS, and enhancing functionalities as per local and global needs. So this kind of in Nepal, we have I have experience for 10 and 11 years of my teaching career. There are less possibility to that we can get problems from government as a academic institution. Until and unless government gives the problem to the institution, academic institution, they could they cannot maintain kind of consistent pooling of the human resources. So because universities last for centuries to centuries. So and new batch of students comes and graduate, another batch comes, goes. Problems, previous problem of the government will be solved, new problems arises. So in this type of problems chronology and students enrollment chronology should be matched, so that continuously university can provide solution for the problem of the government. This could be happen if we tie up with the government ministry, especially Ministry of Health or Health Insurance Board. Building trust between health insurance boards and insurance claimer, because we have seen in previous slides that there are significant number of claims have been rejected by the health insurance board. So what could be the problem with the document, or what kind of things that the claimers make mistakes, and so that the claims will be rejected? Such kind of things could be managed in the claiming process, and detecting false claims faster. As I have seen somewhere that in the content of OpenIMIS Nepal, OpenIMIS implementation of Nepal, that AI based some kind of thing is implemented by the government for detecting the false claim. So how accurate is it? And we can enhance the performance of false detection mechanism by creating or modifying the existing system. Because if it is machine learning based, then we can think in different way. If it is deep learning based thinking, then we can think in another way. The students, we could give projects to the students, and we can have multiple solution, and better solution could be adopted by the government for detecting false claim faster. Payment of claims within the stipulated time. For this optimization techniques should be applied. Assigning graduate, undergraduate projects and thesis related to OpenIMIS would be a kind of generating human resources capacity development for these things, which I have started in some very low level in the for interoperability HL7 FIRE. I have given a couple of projects in this semester. So students were very much interested to learn new things, and it is very systematic. So they're really happy. And collaboration of academic institution with Health Insurance Board Nepal, like some kind of scholarship or internship facility or lab setup, they can contribute to the academic institution, and academic institution will provide the solution for the problem they are facing by the students' project or student thesis. Collaboration with development partners, other stakeholders are needed for global perspective and for enhancing the scope of this OpenIMIS throughout the country. Resource sharing, e-learning courses, training materials, such as we are getting so many resources from AeHIN and other digital health forum in the web. So it is such kind of thing could be more valuable for this integrating OpenIMIS course in at university. Developing community for OpenIMIS could be another initiative for backing up the technical enhancing technical skills among the students. So these are the references I have considered for this my presentation. And finally, thank you very much. If you have any queries, suggestions, and anything, please feel free to ask. I'll try my best to give your answer. Thank you very much.
Thank you very much for that presentation, Professor Rabindra. We have a few questions in the chat box.
Okay.
So to start, the first question is, did the School of Computer Science and Engineering work with the School of Medicine or Public Health on OpenIMIS?
Yes, we are. Yes, as I have mentioned that Kathmandu University has many affiliated medical colleges, 10 medical colleges. Among them, the closest and our teaching hospital is Dhulikhel Hospital. So we have their health-related programs, medical-related programs, and public health-related programs. So we are very closely working with them for this activity.
Thank you, Professor. Our next question is, how is the relationship between HIB and MOH? Are they collaborating well?
I think they are located in the same place and they are supporting each other very much. But as you know, they have their different objectives and they have their different motives. Sometimes they may find the lack of time to communicate to each other and to share their ideas between them.
Thank you, Professor. Our next question is how to ensure the data security and the content quality in OpenIMIS, and who is in charge of those issues?
So it should be like third party. It should be like third parties who are and some different level of authentication should be there, which we normally do in financial transactions. I think that could be thing. And another thing is regarding OpenIMIS data security or health-related data security. It is like a problem of like a research problem. So we can see the system and we could find the vulnerabilities of the data privacy and security, and then we can suggest that if existing solution is fitted for the current problem. Otherwise, we could develop new technology to further data privacy or security.
Thank you very much, Professor Rabindra. I think that's our last question so far. So to all our participants, if you have other questions, please feel free to reach out to the AeHIN Secretariat team so we can relay your questions to Professor Rabindra. Before we officially close the session, maybe we can call on Dr. Bunchay for a few words.
Thank you very much, Professor Rabindra. And it's very comprehensive. And I think this is a good summary about the health insurance, health financing, and healthcare service. And the patient perspective that you explained to us is, I think, it's very intriguing, and I think this is a very good the information for the developer, the insurance, and the hospitals. Thank you very much, and I think we have more time to learn about the progress of the health insurance and health information system in Nepal. And AeHIN are always working together with Nepal on this. Thank you very much.
Thank you. Thank you very much. You are welcome. It's my great pleasure to be a part of AeHIN. Thank you so much.
Thank you.
Right, thank you, Dr. Rabindra and Dr. Bunchay, and also to all our participants for joining tonight's session. We hope to see you again on Wednesday. We actually have back-to-back webinars from 8 p.m. to 9 p.m. and 9 p.m. to 10 p.m. So we'll be using the same room. So please feel free to join us in both sessions. Thanks, everyone.
Thanks.
Good night.
Bye.